in the premaxillary area, I can place maybe 8 mm long implant, 10 mm long implants, no more. Provate a stare più dritta. And this is the CPCT, and this is my planning. You see, I have some bone in the premaxilla, no bone in the back. And if we look better to the premaxillary bone, we can check easily that in this premaxillary bone, we can place some implants for sure, but even in the, here I have the canine area, so here I can place a 9 mm long implant. Even if I tilt my implant, I have no more bone. So even if I tilt the implant, I have 8, 9 mm of bone. The same in the frontal area, the same in the left side. Maybe the left side is even worse. You see that even if I incline my implant, I have no bone to place the standard implant in this area. So I need to put something in the back. I can place the two pterygoid even if I have not a lot of space in the tuberosity area, but I will try to place the two pterygoid, and I will place the two zygomatic implant, because if I check, the sinus is healthy. The sinus is healthy. You see the meatus is open. It's here. So the meatus is open, the sinus is healthy. And if I check, the thickness of the zygomatic bone is good. It's quite, it's quite narrow, it's not very large. For example, to place in this zygomatic bone 2 implants, making a quad, it's very difficult, probably impossible. But in order to place just one zygomatic implant, this bone is enough, because if I measure the thickness of the bone is 13, 14 millimeters. So I can place my zygomatic implant, you see, in this area, for example, with my extra sinus technique, probably a 37 or 40 millimeter long zygomatic implant, engaging the zygomatic bone, which I repeat is not very large. You see that, you see also here in the reconstruction, it's not very large. I need to stay near the orbit, but it's thick. And the same in the opposite side. If I go to the opposite side, the sinus is healthy, the meatus is open. So the meatus between the sinus and the nose is open, no sinusitis, and good thickness of the zygomatic bone. Unfortunately, it's not always like this. Sometimes the zygomatic bone is very thin, and if you have a zygomatic bone which is less than 6 millimeters, you cannot place your implant. The minimum thickness is 6 millimeters. About the pterygoid, I want to add pterygoid in the back. I don't like to place just implants in the premaxilla and one zygomatic implant for each side, because it's risky. Zygomatic implant has bending movements, and so I prefer always to place pterygoid in the back in order to remove this possibility to have bending movements on zygomatic implant, which are very dangerous. If you just place some implants in the premaxilla, 2 implants in the premaxilla, and 2 zygomatic, like a classical hybrid configuration, this is risky, because you can have a failure of the 2 anterior implants due to the overload. On zygomatic implant, you have bending movements, so much more stress is given to the 2 anterior implants, and this is risky. You can have failure after 1, 2, 3, 4 years. So I always try to add pterygoid in the back, and this is my planning. I incline my slice, I go in the back, inclining the slice with this anteroposterior inclination 45, I go in the back, and when the sinus in this sagittal view, the sinus disappears. This is the correct position of my implant. You see, this is a nice image. With the tuberosity low quality bone, this cortical bone. This whiter bone, more cortical, this is the pterygoid fossa, external lamina, internal pterygoid lamina. And what is this? This is the target point of the pterygoid implant. It's the pyramidal process. And so we are going to place our implant like this, perforating the laminas, perforating the pyramidal process. The tip of the implant will stay in between the two laminas inside the fossa, and the same in the opposite side. Remember that pterygoid implant, you see here, I have the sinus, I go in the back, the sinus disappears, this is the correct position. Why is the correct position? Why I want to stay as much as more next to the sinus? Because if I go more distal, I have lower bone. You see? If I stay more near the sinus, I have good bone. If I go in the back, I have less bone, less bone, less bone, less bone, less bone. And so I can place a shorter implant. Remember that for pterygoid, you can use also guided surgery, which is very useful, very easy to use for pterygoid. It's cheap surgery because you just need 3D printing resin guide, so it's nothing very costly, and you can plan your implant. You see, for example, here I plan my implant. I put the this is the JD guide, the JD digital guide, the software for digital planning for guided surgery by JD. I incline the slice 45 anterior to posterior, right? Go to the in the back, looking at the sagittal view when the sinus is clear. This is the correct position of my implant. This is my implant. This is how I want to place my implant. The implant has two inclination, anterior posterior and the medial inclination, vestibular to palatal. You see this medial inclination towards the palatal side, because the maxillary bone turns towards the medial, towards the internal, and this is a nice bone. This is the pyramidal process. The tip of the implant needs to stay 1-2 millimeters inside the fossa, where you have just muscles, no nerve, no vessels. So this is the correct position. And so in this case, I'm going to place the two zygomatic implant, the two zygomatic implant freehand. I'm going to place the pterygoid implant in the left side, guided, the pterygoid implant in the right side, freehand. To finalize my anesthesia on the zygomatic bone, I need to finalize the anesthesia on the zygomatic bone. I already did my anesthesia on pterygoid. The anesthesia for pterygoid is like this. This is the, you see, this is the end of the tuberosity. Apri grande Antonio. Apri grande Antonio. This is the end of the tuberosity. So I go with my syringe like the drill. The inclination is anterior to posterior, 45 like this, and 20 degree vestibular to palatal. I put all the syringe inside, zoom un pochino meno per farvi vedere l'inclinazione. Okay, like this. So I go with the syringe towards the laminas, the third molar area, with this inclination anterior posterior and vestibular to palatal, and then I add some anesthesia in the palatal area. About the zygoma, I make two anesthesia. One is at the infraorbital foramen, which is more or less here under the orbit. So I go with my syringe towards the infraorbital foramen, making some anesthesia, and then I'm going to identify the working area extraorally with my fingers. So I put one finger in the lateral inferior part of the orbit, the other finger where I felt that the zygomatic arch starts. This is the body of the zygomatic bone, which is my working area, and I go with my anesthesia towards that area in the middle of my fingers. Remember to maintain always during the surgery the finger like this in order to always have the possibility to check the position of your drills, to check if the drill is in between the two fingers in a safe working area. I do the same in the opposite side, so infraorbital foramen under the orbit, I go with my anesthesia towards the infraorbital foramen, and finally I will have the anesthesia in the working area in the left side. Apri Antonio, bravo Antonio. One finger in the lateral anterior part of the orbit, the other finger was filled the zygomatic arch, and I put the syringe in between the two fingers, like this, in between the two fingers, in between the two fingers. Okay. I told you that I want to go fully digital with my prosthesis. I have my WhatsApp. Okay, this is the WhatsApp of that we perform it. And look what happened. I open it in the palatal area, the WhatsApp, because now I'm going to take the digital impression, the initial impression, and in order to align this preoperatory scan with the postoperatory scan, I need to have some gingiva, some soft tissue visible. The lab, the software will align the pre and post surgical scan thanks to this soft tissue. But it's not enough. I need to add something in order to have a correct alignment on the two scans, the preoperative and the postoperative. The soft tissue is not sufficient because I'm going to open the soft tissue. I'm going to raise the flap, and so probably the soft tissue will be not in the same position after the surgery as it was at the beginning. So I need to add something. I need to add the JD tracer. The JD tracer is a screw that I'm going to put in the palatal area, in an area in which I'm not going to touch nothing. The screw needs to stay in the same position from the beginning to the end. I use the initial drill, apri grande Antonio, apri grande, in order to make in the palatal suture, in the middle of the palate, a little hole, okay, a little hole in which I can screw, apri, the tracer. So I screw my tracer, dammi anche la... I screw my tracer. The tracer is, the screw is self-tapping, apri. I finalize the insertion with the screwdriver for straight move unit, and you see the JD tracer is self-tapping and has this geometry in the top. And thanks to this geometry, I will align, the software will align the pre and post surgical scan. It's very important to place the tracer in an area in which you will not have any interference with the surgery. You see? An area in which you have no interference with the surgery, and thanks to this geometry, the pre and post-operative scan will be aligned. Please check always that the tracer is very stable, needs to be very stable. You cannot have any movement. Then you see your WhatsApp, the tracer is in the middle in the palatal area, and so now I can scan. Tieni il labbro, tieni il labbro. Tieni il labbro. We can try to have a little bit more, but you see this tracer, it's enough. Take some more soft tissue, but it's enough. Thanks to this tracer, I can align everything. So I already took the chiudi pianino so this is done. Apri. This is the only occlusion that I'm going to register, because again I'm going pressing one with your sleeve. I suggest you always to put 2 pins in order to fix the guide in the palatal area. And so you fix your guide, apri grande. You fix your guide with a pin. Apri. Second pin. Apri. Second pin, and last one. You see, the tracer is always in the middle. Okay, I check the position of the guide thanks to the windows. You see, I have windows for inspection here, prestally, and in the palatal area. I always keep pushing the guide with my finger in the palatal area, the tuberosity area, and I start making my osteotomy through the sleeve 2.46 millimeter. 2.4, 10 millimeter. I just use the 2.4 drill through the sleeve. Two 2.4 through the sleeve. 2.4 through the sleeve. And now it's finished. I can remove, apri. I can remove my pin and check my osteotomy. I use the guide just to make the osteotomy. So it took to me few seconds. And look, the osteotomy is done. It took to me few seconds and the osteotomy is done. Okay? Okay, so start now, happen. Start now with the incision. Apri grande. I always suggest you in the tuberosity area to perform a little double incision. Try to stay a little bit volatile in this case, in order to have a nice thick soft tissue vestibular to the zygomatic implant. At the beginning I perform in the tuberosity area these 2 incisions in order to remove the excess of soft tissue, to have a better visibility in the tuberosity area in order to place my pterygoid. I continue staying palatally with my crestal incision. I stay parallel with my crestal incision. I go in the opposite side, I do the same, parallel incision. I want a thick, soft tissue vestibular to my implant, zygomatic implant. I make a double incision in the back in order to remove the excess of soft tissue si vede in già. Ok? I remove the excess of soft tissue. Then I perform the 3 vertical incisions for Zygoma, apri. The first incision is in the midline. The other 2 incisions are in the back. Si vede? Quando si riesce a vedere, prova a zoomare un filo di più. Quando hai l'inquadratura, no? Apri. Ok. Dall'altra parte. Apri. Also here, I perform the vertical incision. Okay. Then I'm ready to write the flap. So remember the 3 vertical incision, 1 in the midline and 2 in the back. I write my flap first palatally. Bravo Antonio! Forza che va tutto bene! Parlo in inglese perché sto spiegando a dei colleghi il tuo lavoro, che è molto interessante, sai, il tuo caso è molto interessante perché è un caso particolare, dove c'era poco osso, e allora lo sto spiegando ai colleghi. Per questo senti parlare in inglese, siamo tutti concentrati qui per te. Ok, so I write the flap palatally and I go for a cross suture in order to maintain the flap elevated in order to have better visibility. So cross suture okay. 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 And now we go rising the flap. First vestibular. Dammi per favore il video. Ok. Okay, so I write the flap, vestibular a little bit, and then I go on the opposite side. And I write also here the flap. In a little bit the bone and removing the periosteum which is attached to the bone. This helps me in understanding better the anatomy of the bone. the anatomy of the bone. Vedete bene Alice? Alice? Vedete bene? Parla. Okay. Now I'm going to use the rounded ring. Okay. And we start now first with pterygoid. Behind the tuberosity. So this part goes behind the tuberosity and this part goes exactly at the base of the fossa. These two will go around the laminas. And if you place this instrument behind the fossa, this plate will be inclined 45 degrees, and you see the handle of the instrument is inclined 20 degrees. So, following the central laser line, this one, the central one, you will have the possibility to have a perfect reference of the inclination of your drill. If you put your drill parallel to this laser line, your drill is inclined 45 degree, 45 degree anterior to posterior, and 20 degree, 20 degree vestibular to palatal. Apri grande. This is the end of the tuberosity. Yes, you see, this is the end of the tuberosity. This is exactly the end. I need to put the instrument, I need to put the instrument behind the tuberosity. You see? Like this. Okay? I put the instrument exactly, look, exactly behind. This is the tuberosity. This is the instrument blocked, perfectly blocked in the area. I report the entry point that they measure on the CBCT. The entry point of my drill was 10 millimeter. Okay, so 10 millimeter. Aspira. 10 millimeter, and I follow the laser line in the middle. Si vede? First drill. Dimmi come devo stare per far vedere. Apri. I need to follow the laser line in the middle of the instrument. Ok? Proviamo a farlo. Si vede meglio? Tieni per favore qua in dito. Laser line in the middle of the instrument. I know that I need to place a pterygoid which is 15 millimeter long, 18 millimeter long. So look, the drill is parallel to the line. Si vede? I'm now at 13 millimeters. See that? And I'm inside at 15. Perfect. So I use the last drill of the Pterygoid tip. This drill is going to make some space in the cortical part of the osteotomy, and here we are. Suona. We go the opposite side, apri. I need to isolate again the tuberosity, okay? Following the osteotomy making guided, respira per favore. Here I have maybe a little bit more bone. Non si vede. Ok. Andate di nuovo a due. Un attimo. Okay. So this instrument is very useful, of course, especially if you want to place the pterygoid freehand. It's called JD Pterygoid retractor. Diciamo anche qua, mi dai per favore il codo. Dai di nuovo il contrasto. Prego. JD Pterygoid retractor. Ok. Okay. Now we go for the two anterior. No, okay, now we place the implants. So we place the Pterygoid implants 18 mm long in order to check the stability. I'm going to place the implants in order to check the stability. 18 mm long, Pterygoid implants. Apri. Apri per favore. Si vede qua? Place the implant, no, ma devi zoomare. Place the implant slowly at the beginning in order not to deviate, not to have any deviation on the trajectory of the implant. You see the inclination 45 degree anterior to posterior, 20 degree vestibular to palatal. And at the end, in the last part, the implant start getting stability, start taking stability. Fagli vedere, zoom a meno che gli fai vedere l'inclinazione. You see? And I finalize the insertion. Fammi guardare il torso. And look, if I put again the Pterygoid retractor, look, the inclination of the implant is parallel to the laser line in the center of the plate, you see? The inclination, apri, is parallel to the laser line at the center of the plate of the instrument. And if I check the stability, fagli vedere il crichetto. If I check the stability of the implant, fagli vedere il crichetto, it's around 80. Okay. I place the implant in the opposite side. Non si riesce a vedere. Again, if we check with the retractor, it's parallel. Apri. Apri grande. Apri grande. Always leave some bone distal to apri grande. It's parallel to the laser line in the center of the plate. Leave some bone distally to your implant in order to have no risk of fracture of the tuberosity. So always measure exactly the entry point of your implant. It's very important. Okay. So the two anterior. I need to identify the nose. Senti male? No. Sì, fa cosa? Analisi. Ma qui senti male? Sì, dammi nel sedere. Osteotomy. And the same here. Apri. The same here. But it seems to have a little bit more bone. 2 millimeter. Now I'm going with a 2 millimeter drill. 2 millimeter drill, and then 2.5, 2.4, sorry. 2.4 till the base of the nose to get the bicortical fixation. You see, I'm a 10 millimeter long, 10 millimeter, 10 millimeter, 10 millimeter, 10 millimeter inside the nose. And then I use the bone track drill. You know the bone track drill, the drill with the tip which is 2.4 millimeter and the body of the implant which is 3.7. I'm going to place 3.7, 10 millimeter long one. So bone track drill to finalize the osteotomy, leaving the osteotomy under prepared in the for the apical portion. The apical portion is 2.4 millimeter, and so I leave this under prepared. I prepare just the cortical part of the osteotomy 2.4, 2.3.7.10. 2 mua da 30 da Pterygoid, 2 mua dritti normali. Apri. Now I go with the 2.4 again, apri. 2.4 again. It's 8. Apri grande, per favore. And again, it's 10 and 10. I'm into the nose. So bone track drill 3.7. Okay, bone track drill 3.7. Apri grande. And that's it for the two anterior in the premaxilla. Okay. I want to check if I'm parallel. I can move a little bit, this like this. Okay. In order to make the osteotomy more parallel. You see, more parallel. Okay, now it's time to go for Zygoma. So, I have a special protocol to raise the flag for Zygoma. First of all, you need to identify the nasal cavities. Aspirate. And then, as first step, push the elevator towards the lateral wall of the nose. First step. And this is all the nose. Okay? Apri? This is all the nose, you see? Ok? C'è pochissima luce, perché non c'è luce così. Facciamo vedere così. Ok? Then I take my elevator and I start pushing the elevator in the distal area. towards the zygoma, you see? I push the elevator towards the zygoma. This is the second step. And the last step, I take the gauze with my finger. I put the finger and inside the mouth, with the other finger, I'm going to identify the working area and I start pushing. I start pushing the flap till I reach with my intraoral finger the extraoral ones. I need to push, okay, and reach with my intraoral finger the extraoral ones. Okay, when I feel with my finger that I'm touching the extraoral ones, I take my Minnesota elevator. Apri per favore adesso. I put the elevator, un attimo. I put my elevator. Here. The nose. Here I have the nose. I want to try to see better. Nasal cavities, infraorbital foramen. Fallo vedere che si vede bene, dai. Infraorbital foramen, okay? And here I have the white fiber, the insertion of the masseter muscle on the zygomatic arch, here. So first of all, I take a pencil. The starting point of the implant. Pressed. This is the starting point of the implant. Then I need to design the access to the sinus. This is the fibers, okay, here. And so I start designing. I come 5-6 millimeter mesial to the white fiber, and I start designing. You see the white? Per 10. The access window to the sinus is 8 per 10. I need to perform the access window to the sinus in order to try to maintain the integrity of the membrane, and in order the pencil line is in between the two fingers extraorally. Fai vedere, zoom un po' meno. You see here I put the two fingers extraorally, lateral wall of the orbit, and the other one I'm in the middle. You see that I'm in the middle with the pencil line? I'm in the middle, so I'm safe. And I can start. The bone in order to have access to the sinus. Bene. Okay. So now I take the elevator and I push the membrane inside, trying to maintain the integrity of the membrane. I push the membrane inside, and every time is always the same. More up, it means that the base of the bone is higher. So I need to take again the rounded drill and push the drill from inside to outside. From inside to outside in order to reach the base of the zygote. Here is the bone. Here is the bone. This is the base. The elevator does not go more up. See that? Okay. So now I can put the initial drill. Done. And I push the drill in order to be totally inside the maxillary plate. No, stai fermo, Antonio, fermo. Ok. Apri per favore. I'm creating with this drill the space for the body of the implant. You see the membrane until now is intact. I need to go a little bit more inside with the drill, but it's almost done. You see now the body of the drill is totally inside the maxillary plate. It's totally inside the, once the drill is totally inside the maxillary plate, you stop. And look, the membrane is intact. So now I can take my first drill. Tieni, devi spingere forte perché è durissimo. I put the tip of the drill in the middle of the bone that I see with my eyes, yeah? And I go inside. First drill. Second drill. Apri. Dai, t'ho fatto. Forza e coraggio. Apri grande. Apri. Okay, and now I'm outside. You see the tip of the drill? I have bone. So I put my probe. I take the reference. I feel with the probe that I'm outside. Ok, 30, 35, 40, 42 e mezzo mettiamo, Mettiamo un 42 e mezzo, potevamo mettere quasi un 45, ma meglio mettere un 42 e mezzo. Apri. Un attimino, via poco. So if you look, the membrane is intact, and here I have the hole. Non so se si vede, ma here there is the hole. Sì. This is the hole, you see, this is the hole. Okay? This is zygomatic arch. So again, I take the pencil. I come down, this is the infraorbital, and so I come down. This could be the entry point. Okay, then I stay 5-6 millimeter mesial to the white fiber, designing my window 8 per 10. 8 per 10. I design the trajectory of the implant, which will be like this. Like this. Like this. Okay. And now I start. I like to make this window in order to have visibility. I want to have visibility of what I'm doing. I need to see where the base of the zygomatic arch, the base of the zygomatic bone is between starting drilling. You see again, the tip of the elevator goes a little bit more up, so I take the rounded drill and I go a little bit from inside to outside in order to arrive at the base of the bone. This is the base. Look how you can see now the base of the zygomatic bone. You see perfectly. So you take your diamond drill. Tieni, Alice, un attimo tu. Vai. Diamond drill, apri. And you go inside the maxillary bone. Okay? Apri. I take out again, look the membrane is intact. This kit from JD for Zygoma is fantastic. You see the membrane is intact. I push the membrane inside a little bit. You see the bone? Okay. And now I can go make my osteotomy. Apri. First drill. Apri. 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 Okay, apri grande, Antonio. We go. We go. Forti. Apri un attimo. Okay, apri, fine. I took a lot of bones. Really a lot of bones. Apri. Sì. Ok, abbiamo finito. Apri grande, quasi finito, stai fermo. 45. Okay. And I perforated externally the zygoma, so I check again, I check again, I feel that the proof I feel that the bone come outside, so I check the length and I want to show you again this fact. The membrane is intact and here is the hole. Faglielo vedere the hole. Sulla testa, un po' sulla testa, bravo, aspira dentro. This is the hole. This one. You see? So I'm totally outside the sinus. I'm totally outside the sinus, but I'm totally into the maxillary bone. So now I can place the implant. Tieni un attimo, Alice. Okay. Zygoma 1, 45 mm long. This is the implant. Ok? Apri grande adesso, apri grande, apri grande, apri grande, apri grande, apri grande. I engage the hole and I start screwing the implant. You see the implant collar is totally inside the maxillary bone. Is totally inside the maxillary bone. Aspira. Fai vedere che sono dove fa. Zoom un po' meno, zoom un po' meno, zoom un po' meno. Bene, good, good. Very great stability. When I'm near to the final position of the implant, I'm near to the final position of the implant, great stability. Okay, now I take the Zappa tool, this other tool, in order to check exactly I bring the final position of the implant hexagon in order to choose the multi-unit attachment correct. So I rotate the implant till the final position and I can select exactly the multi-unit attachment that I prefer, which in this case should be apri, avvicini i denti, chiudi un po', piano, apri, should be 60. Then I put the 60 and I go in the opposite side, apri, look, this is 60, you see, and now occhio che devi mettere la luce adesso, aiutaci. Zygoma implant, Zygoma 1, apri, again 45. I'm totally outside the sinus, so no risk of sinusitis. Totally inside the maxillary plane, the maxillary bone, in order not to have soft tissue recession, in order to have an attachment between the collar and the crestal bone to have no bending movements on the implant. And when you are near to the final position, again, take the Zappa tool in order to choose exactly the final inclination of the multi-unit attachment. Which also in this case should be 60. Yes, 60. That's 60. Ok. Adesso metti quest'altro fondo. Apri. Ok. Apri. Multi-unit, 60 degree. Apri. 30 Newton screw. And the final implants are the two in the premaxillary bone, 3.7, 10 millimeter long, you remember? Here. Nice ability, thanks to the bicortical fixation with the nose. Always, you have to get the bicortical fixation with the nose. Always, in order to have a good primary stability. Look at the primary stability. So you can go with immediate loading, safe, safe, safe. Multi-unit 30 degree. Sorry, multi-unit straight. Multi-unit straight. We screw the multi-unit. 30 Newton. Okay, 30 Newton. Then, okay. Multi-unit 30 degree on pterygoid. Always I use a multi-unit 30 degree on pterygoid, always. I screw with this very useful long screwdriver, beautiful one. Really beautiful, I like so much. So much. Happy? And now I go with the multi-unit here. Okay, okay. And this is the final. So, two implants in the maxillary, in the premaxilla with nasal anchorage, two pterygoid, two zygomatic implants with extra sinus technique. Zygoma. Apri grande, apri grande, apri grande, apri grande, devi prendere tutto, metti bene la luce, metti bene la luce, apri grande, dai che abbiamo fatto, non sei stato bravo, di più. Apri grande, non c'è luce ragazzi. Zoom, tira. Spruzza un po' di acqua. Via. Apri. Tira. Apri. And this is the final. You see? Okay, no problem. Okay. Now it's time for photogrammetry that I use in order to transfer the position of my implant, in order to detect exactly the position of my implant and have the possibility to fabricate a passive framework, totally passive. You see, I use this scan body for photogrammetry, very easy to use because I just screw the scan body in a few seconds with my hands. I'm going to take two scanning. The first one, the first one will be on the two anterior and the two pterygoids. Apri. You see, this is the first scan. Apri. Two anterior and two pterygoids. We will talk tomorrow during the Congress about photogrammetry, which is one of the latest and best innovation on full arch. I need to place the patient more up, the machine in front of the head of the patient. The machine has this light, green light, and I start with my scanning. Here I have the two posterior implants, the two pterygoid are very posterior, so I need to try to move a little bit the scan in order to detect or the possibility that all the implants are detected. Okay. When you have also zygoma, you have the metal of the zygoma that can, of the body of the zygoma that can make some interference, so you need a little bit more time. apri. Okay, now the scan is complete. You see for the
Very good. Thank you for the presentation.
as I always say, you know, daily symposium, software is matching. Scanner scanning the on top and the soft tissue. So now I'm going to suture and I finalize my full arch, full digital protocol with the intraoral scanner scanning the scan on top, the gingiva and the tracer. So to summarize the full arch digital, the steps are: first you scan the preoperatory situation with the tracer in the palatal area, or if you are in the mandible you need to place two tracers, one in the anterior area, two tracers in the second molar position, one on each side in the second molar position. So first you scan the gingiva and the tracer, and then you do the surgery. Of course, you scan the opposite dentition, you scan the occlusion, and then you perform the surgery, you take the photogrammetry, you suture, and you take the final scanning with the scan on top and again the tracer. These are the steps. All these SDL files will be matched and will be aligned by the software in the lab, and the technician will be able to start immediately designing the prosthesis. So if you have any question, you can perform your question during this suture time. This is the situation. You see the nice symmetric profile of the implants, and now a scan. Tracer, the palatal, gingiva, and all my scan on top. You see, this scanner is shining a light, a lit. So I could use the photogrammetry by shining a lit purifier, but I don't like it. I repeat, it's more time